Welcome everybody to this second panel of this Congress. Welcome to this Prioritizing Sexual and Reproductive Health in Conflict and Other Crises panel, the topic of today. Just quick reminders before we start with our panelists. So whenever you want to comment about this panel or in general about this Humanitarian Congress, please use the Twitter, the hashtag HCBerlin. You're also very welcome to post questions in the Zoom Q&A window, the button just down the screen. If you are in the live streaming session, you cannot do that, so please join us on the Zoom link to do that. You also have live captioning, so you have a French live translation always in a Zoom link, so please do join us on the Zoom link to have your French translation if you need one. And then if you're all good, we can start talking about this very interesting topic. So today we'll talk specifically about MISP. What's the MISP? So the MISP, it's the minimal initial service package in sexual and reproductive health services. And it's a coordinated set of priority actions to be implemented at the onset of a crisis. It's a validated international norms defining SRH essential services in order to maintain the healthcare continuum and provide immediate response to SRH needs and therefore save lives. It's very important to notice that it's a package developed by an inter-organizational working group on SRH. And this group has been composed by UN agencies, NGOs, university research bodies. That makes it very complete and comprehensive. So again, which are these priority actions? So the MISP highlights 6 specific activities. The first one is coordinating the MISP activities in itself, which is a huge work in itself, preventing and responding to sexual violence and addressing the needs of survivors. Reducing transmission, morbidity, and mortality caused by HIV and other STIs. The 4th objective would be to reduce the excess of maternal and neonatal mortality and morbidity. And 5th one is preventing unwanted pregnancies. 6th, but not the least one, is planning the integration of the comprehensive SRH services into primary care services as soon as possible. So today, throughout this panel, we will explore how humanitarian organizations can prioritize SRH services and modes of delivery. And we will also very critically, of course, examine the patriarchal structures that influence these services within the humanitarian organization. We'll also, of course, analyze the relevance of the MISP from a feminist perspective. And we'll do that with the help of 3 colleagues here today with me. So I'm very happy to introduce to you Diana Mania Arroyo, the gender and health expert at IFRC. Thank you for being with us today. We have Dr. Amina Aminu Durai, the Nigeria country director at Pathfinder International. Welcome very warmly at our panel. And we have Dr. Rania Abu Al-Hassan, the regional humanitarian advisor at International Planned Parenthood Federation for the Africa and Arab regions. Welcome, Rania. Welcome, all of you. So, as we just said, the MISP, so these 6 objectives, which are very, very practical, right? They're often not known, not recognized, partially implemented, or even not theoretically accepted. Why do you think, in your opinion, why do we have these barriers against MISP? What could be the barriers that prevent actually the implementation of the MISP from the onset of a crisis? And therefore, what component of the MISP do you think are partially implemented? Why? And what we can do to change this problem? The floor is yours. Welcome to give a solution, of course. Yes, please.
Yeah. Okay. Yeah. So I can start, Frederica. Good morning, good afternoon, and good evening, everyone. And thank you for your very critical question. So for me, I think the MISP tool is a very great resource for SRHR in crisis situations. It is quite comprehensive, as you mentioned, with all the critical elements of SRHR in both crisis and non-crisis situations. But as you mentioned, it is unfortunately not implemented as it should be, or even in some cases, it is not known. But the barriers, in my view, are quite multiple. And I'd like to highlight just a few for the sake of time. First, for such an important tool to be utilized, I think critical stakeholders within the affected communities must be aware of the tool. They must take ownership of the tool by contributing to its development, actually, and adaptation to local context, and have the required capacity to actually implement all the elements of the tool. But unfortunately, most national and subnational governments are yet to prioritize these tools, and they are yet to also put efforts, in ensuring that it is implemented, especially, and enforced. So there are many other competing demands. Usually in crisis situations, we all know that there are a lot of competing demands, especially in emergencies. So unfortunately, SRHR is not regarded as life-threatening. So most of the time, the already scarce resources are diverted to other emergency preparedness and service delivery initiatives that are considered, more important during emergencies. But I think in many of these communities, let me say this, that most of the leaders are actually males. And I think maybe they may not feel directly connected to the issues of SRHR and why MISP is very important and should be prioritized. So in my view, having a good mix of genders in decision-making could help in breaking these barriers and addressing the power dynamics that often comes with these gender inequalities. But just like development, in the development community, there's clamor for locally led interventions, but I think there should also be clamor for female leadership across various levels of health sector, because when they understand SRH better, they can be able to make informed decisions on behalf of their agenda. And I just think it's a fair thing to do and the right thing to do, to have, especially women in leadership, that will help prioritize MISP. Thank you.
Definitely. Thank you, Aminat, for raising all these important topics. And then you just mentioned a few of them, like gender equality, women in leadership, women in peace organizations. Absolutely, definitely. But then I will leave the floor to Diana, who wanted to say something before. Please go ahead.
Thank you. Yeah, I think it's important to recognize, as you raised in your question, that some elements of the MISP may perhaps be more acknowledged or prioritized than others, which is a challenge in itself. And the barrier to that prioritization, I think, is rooted in patriarchal concepts of women's roles in society. So from personal experience in a range of health humanitarian projects in the field, I can say that a component of maternal health was almost always an element of the package of care, often in the shape of emergency obstetric care. But I cannot say the same for components to prevent and manage sexually transmitted infections, care for sexual violence survivors, or safe abortion care. So by no means I'm saying that there is nothing left to do in terms of improving access to maternal health, but instead what I think it's important to recognize is that it's how other elements of the MISP are deprioritized. And I think it's worth analyzing the role of patriarchal concepts of women's roles within the family, whereby women are often valued based on their ability to reproduce. And I think in the humanitarian sector, these patriarchal concepts often get translated into the prioritization of maternal health at the expense of other issues like adolescent sexuality, abortion, diversity in sexual orientations and gender identities, and also at times even gender-based violence. So all of these elements, I think, are increasingly recognized as an important and are part of the MISP, but in practice, they tend to be deprioritized in comparison to maternal health-related interventions.
Definitely. Thank you. Thank you very much for this contribution, Diana. Rania, please, I can see you want to say something.
Yeah, I'm just thinking about all of the spectrum of the humanitarian crisis that we have, like the natural disasters, moving from natural to, like man-made disasters, but also thinking of the affected, countries' conditions, because we had, countries who are already in a very stable condition. They are very advanced. They are, like very developed countries, and you have countries who have already their health systems are not even developed yet. So one of the struggles that we have faced also into some modern or developed countries is the convincing force that we need to put for the medical support workers to go to the basics of the to go to a minimum thing, because what they are using is the maximum, which is not like the six objective of that is already endorsed in the setting. So now here comes the humanitarian responders coming from outside and trying to start implementing something which is very basic for the practice, which is already exists in the country. So that's also one of the struggles that we had in some of the developing countries or the advanced countries in the region. And I think that's a very big obstacle to look at it and to try to make the advocacy tools that, yeah, we are doing this now, but we need to, and so sooner we will get back to the norms that we are doing as fast as possible, as objective 6 is indicating. I think this is one. Thank you.
Thank you very much, Rania. Thank you, all of you, for raising very important elements on understanding why MISP is partially implemented. And then I wanted to take over from Rania and then going in this sense. So in these recent years, we are seeing more and more chronic and recurrent crises, right? Such as Syria, DRC, Haiti, Yemen, but also Horn of Africa. Do you think it could be possible, and if yes, how? Maybe you have still solutions or lessons learned from other your experiences from the field to prepare the MISP before the onset of a crisis. I think getting prepared, understanding what we can do, not leaving behind some of the elements, as Diana was saying, for example, yes, maternal care, but no sexual and reproductive health for youth and adolescents. Do you think it would be possible to be prepared in such of this context where a crisis is there since years and will be there for probably, again, years and years?
I can start?
Yes, please.
Okay. So I do think that there is space, especially during during the transition from emergency to a more stable situation, to, as you said, prepare the MISP. And I would like to specifically focus on engaging with local organizations. So to give an example, I worked in Haiti in 2016, which is a country that faces crisis on a continuous basis, unfortunately. And I worked in a project offering sexual violence care, and we partnered with an organization that focused on the defense of rights of the LGBTQIA community. And so what we did was was awareness raising sessions on the medical consequences of sexual violence and on where to seek care for their teams to later on do the same sessions in spaces where they only had access, only them, I mean. And this was useful and efficient because they already understood gender dynamics in that specific setting, and they already had acceptance by that group. And they already had a clear engagement strategy with this group. So we didn't necessarily set up a program with them, but instead we supported what they already had running and simply created a bridge between their target population and our healthcare services by ensuring that these were inclusive and respectful. So I think this is something that is useful and that can stay as a basis at times of crisis. And to a certain extent, it can prepare for the delivery of the MISP. And another aspect I'd like to mention, also related to local organizations, is I think that the role that feminist local organizations can have. And I think that they have a lot to teach to the humanitarian sector in terms of identifying and calling out not only sexist practices in healthcare provision, but also on identifying and calling out certain colonial structures that are, I think, rather characteristic of the international aid system, you know, in and outside of the emergency setting. So when I refer to those structures, I mean structures where we as members of humanitarian organizations prefer to speak about alleviating suffering in an emergency rather than about addressing justice, where we prefer to talk about misfortune rather than about the domination of patriarchal structures, where we prefer to address exclusion rather than systems of inequality, or where we choose to address trauma rather than the violence that causes it. So I think that feminist perspectives are really useful to turn that discourse around. And too often, I think also the humanitarian system is structured in such a way that there is some type of expectation that those at the receiving end of assistance have to show gratitude for the aid received rather than expressing demands for their rights. And feminist organizations offer an alternative to break with this structure by focusing perhaps less on alleviating suffering and more on empowering women to demand access to information, to demand having control over their own bodies, to demand protection for their sexual and reproductive rights. So I think this engagement with feminist organizations, it's an important way to prepare for the MISP, and in fact should serve as an inspiration to any organization working in sexual and reproductive health. Thanks.
Very, very true words, I think. I will comment them later. I just want to leave the floor first to Rania. I think she wanted to contribute, right?
Yeah, like it's very interesting also, preparedness or preparation, or like MISP, like what are the projections that we carry as humanitarians for crisis onset? Like how can we tell this is a place that we need to put a preparedness action for MISP implementation, or what are the criteria that we cannot prepare? Like it's a very tricky question, and I like that question very much because it is different between humanitarian settings where it is a human like man-made disasters, or climate change, because it's easier when it's a climate change. Like for example, in the Pacifics where IPPF was preparing, they have a very solid preparedness plan for implementation of MISP, because they know the time of the hurricane. So the hurricane will come at this time of the year. The Minister of Health is alarmed. The women, the Ministry of Women is part of that. The grassroots have already, been part of the, dispensing the message, working with the communities, preparing them for the time of the hurricane, because the hurricane is coming. So the preparedness in that is very easy, because people can predict in some extent better than the man-made disaster, where the preparedness is happening at the same time at the onset of the crisis itself. So you find ministers of health in conflict-related situations, they are starting now raising funds because they haven't thought about it before, but in the same time they are starting preparing the staff, and they are starting putting some activities on the ground, waiting for some funds, waiting for some trained person to come on the ground, hitting. So this is like, it's very big difference between the two situations. But as Diana said correctly, like we need to have the women grassroots organization and the feminists oriented prior to all of this. And I think one of the very big venues that we have as organizations, like collectively together today, that we have our outreach teams, we have our hands into the community, that we can start talking about it and prepare for the implementation of MISP and the response. And especially that's really speaking about women's health. Yeah, as Amina said correctly in the first question, that because it's reproductive health, because the reproduction have been seen, like across the generation, is the women's responsibility. So nobody have planned for it. And this is where we start. Thank you.
Definitely. Thank you, Rania, for this very, very interesting contribution. I don't know if Amina do you want to add something, or?
Yeah, thank you, Federica. So I totally agree with Rania and Donia, really very true. I think for me, your question about, preparing for MISPs either before, a crisis, I think in my view, because of the critical and important nature of the services that are supposed to be provided with the support of MISPs, and also entailing the whole healthcare levels, from primary, secondary, tertiary, with a lot of referrals, and it also entails all the health system building blocks, in my view. So I think, to me, MISPs is actually a health system intervention, and the best time to prepare for planning and implementing MISPs is actually, at every time before the onset of any crisis, because when a health system strengthening intervention like this is only left to maybe emergency situations, and in most of our countries, obviously emergencies take place abruptly without time for preparation, and also the health systems are really, weak and underprepared. And then during emergencies, there are many other competing life-threatening needs. So I think for me, I look at this as a very important health system intervention that we all need to ensure that all the building blocks, if I may say, for MISP and for all the elements of the services that are being provided should be prepared before a crisis and should be strengthened so that at least for instance, let me give an example. We all know that, people, as we said earlier, neglecting SRHR services because we assume it affects one group or some groups of the society. But we all know that SRHR affects everyone, even the populations yet to be born, because, during emergencies, there's high rate of gender-based violence, unplanned pregnancies, and then, all these that are prevalent during crisis. And I like the idea of working closely with feminist grassroots organizations, because for me, these are the organizations that are on ground, that know the issues and that actually know the solutions. But, what we are all supposed to do is to provide that technical support to actually work with them and see how we can all integrate services and make sure that MISP is within the health system and not only, planned for emergency situations. Thank you.
Thank you, Amina. Thank you, all of you. And then if I can just add on top of what you said, which is almost the solution. So please, people out there, write down everything they said. It's the solution. We will have something to work on in the next days for humanitarian actions and SRH. I think we are not talking about one side of the population. We are talking about everybody, as Amina was saying. And then a very great example of Rania is that we know somehow when a hurricane is coming, when we have a seasonal peak of malaria, a seasonal peak of, for example, malnutrition, and then we can prevent the disaster maybe somehow. And maybe not always, not every time, because in man-made, of course, crisis, it's very, very not easy to predict with some time ahead, right? But then if you can start somehow throughout natural disasters and then predicting, preparing, making connections with local and grassroots feminist organizations, they know what they are talking about. They know gender roles within their communities. And of course, they will be there when we leave, right? So why we don't engage with them prior to the crisis, prior to the tsunami or whatever you want to add as a natural disaster, right? And then this leads me to the next question, which is in the idea of preparation, as you said, you think, so having heard what you said is that I think for you it would be possible to tighten meaningful engagement and links with the local communities and especially civil society organizations. But then when we talk about humanitarian actions, we all say, oh no, there is no time. We are out of time, out of money. We are here to save lives. Don't talk about community. Let's stop with sensibilization thing, whatever, blah, blah, blah. We are here to save lives, doing operations, and then halas. So how can we balance this mandate of humanitarian people saying we are in a rush, we don't have time, we don't have money, we need to act to save people. And then on the other side, working with grassroots organizations, feminist, civil society organization, how can we do it? Of course, first of all, is it possible? for you, and then how can we do it? And then maybe you also have great examples for us to share with us, to let us understand how can we do it practically.
So I can actually attempt to start, Federica.
Please.
So I think, the issue about engaging local communities and, especially feminist organizations is very critical, as we started talking about earlier. So I'd like to also give a very important example from the work Pathfinder we did in Nigeria, and through a project called Evidence to Action with funding from USAID. So this initiative was aimed at strengthening the response to sexual and gender-based violence in about 9 states of Nigeria through providing technical support to what we call sexual assault referral centers, or SARCs. And these SARCs are actually expected to do a lot, from providing services for SGBV survivors, including providing emergency medical treatment, counseling, forensic care, and also advice on sexually transmitted infections, HIV, risk of pregnancy, and others. So, and most of these SACs are actually civil society organizations, and they link up with the police and welfare departments. So they're really on the ground. So I think that being community-based organizations, being civil society organizations, it's very important to build their capacity, especially where we find some gaps. So we did an organizational capacity assessment. We worked with them to kind of become advocates for the health and rights of women and girls. And now, these organizations are really sustained because they were there, as you say, before we even came. And some of the state governments have actually included funding for them through their own budgets. So other governments and private sector too have also been supporting them with linkage services, capacity building. So really our experience is that many of these local organizations have already started adopting feminist approaches and are very eager to contribute, but may not even have the required resources or organizational structure to implement all these aspects of MISPs. So I think, what programs need to do is to be deliberately designed to engage local communities, and resources should actually be, really earmarked for organizational capacity building and building of technical skills so that they can sustain these services both before, during, and after crisis. So this is just a few of an example that I thought to share, and I believe anybody that comes, any organization is already working with these organizations, and they're all doing a lot, and most of them are already feminist organizations, but it's just to maybe continue to provide that technical support and assistance. Thank you.
Thank you, Amina. Thank you, Amina. I do agree. Technical assistance in coaching and reinforcing capacities is very huge work we should do, and we should not forget just because it's a crisis and we don't have time. Right. Please, Rania, go ahead.
Yeah, I will start from the point that Amina was saying, like when she was saying that before, during, and after the crisis. When we are thinking about, putting that together and trying to implement and advocate, we need to think on a matrix way, because we are not just speaking to the grassroots, because the grassroots, if the donor have not been convinced, they cannot do anything. So it is the layers of having, the grassroots who are here picturing the recipients and the community, with the national organization who are putting the action, and then the UN agencies and the humanitarian structure which have been put in place, channeling the funds, and the upper layer, which is the donors. It's a matrix. What you should do, and every time, for preparedness, with the donors, with the UN agencies or the humanitarian clusters, with the grassroots organization, and with the international organization. It's like a very big matrix of what to do and when and where. And that is the only thing, because, you know, like we have in Arabic a say that, you know, like one hand cannot clap. One hand cannot clap. You need both hands. So if you want to hear, to have a voice, you need to have both hands oriented that you need to clap the other one when you need to do it. So this is why, like, I'm thinking that let's start by having the layers, orientation of the layers, training. Like the MISP, they were like those packages, the package for the donors. Let's start, you know, like advocating for more, you know, like for more use of those available. I think they were available, not in this in this time, but there were some of those handles available for utilization to advocate for MISP and to try to convince. In IPPF, actually, and I want to highlight this because I think this is one of the best practices in all of the, or like in all of my career, is that we have a humanitarian team who is already globally, you know, advocating and gathering funds for you know, MISP applications. And there is you know, like there is priority countries under some donors who are already providing MISP under the sprint, the global sprint. So they are already implementing the 6 objectives. But there is also, you know, like the preparedness and the pre-positioning, which is already happening through the MAs of IPPF and the organization that we have on the ground. So I wanted to highlight that as one of the best practices. Thank you.
Thank you. Thank you very much, Rana. It's very interesting. And it's very interesting to hear from you and from your lesson learned and from your experiences. Diana, do you wanted to say something? Yes, please go ahead.
Thank you. Yeah, I'm going to bring the conversation from the point of view of the donors and from the consideration of the donors a little bit further down and inside our own houses. Because so to go back to your question, Federica, you talked about this argument that in an emergency there is no time to do a certain number of things, such as engaging with communities. I think that's something that perhaps all of us in the panel have heard before. And I think that indeed there are a number of priority activities that are very clearly laid out in the MISP as life-saving and should be prioritized. That said, as soon as basic services are established, it is a matter of dedicating the necessary time and resources to engage with communities. And this is not impossible. I think more often it's an absence of internal willingness to invest in understanding certain dynamics than a true lack of time or resources that is a problem. So I think that if we agree that there is a clear relationship between disease and inequity among women on the one hand, and the material, structural, and symbolic conditions that are imposed by patriarchy on their lives on the other hand, that it shouldn't be a question whether we should invest in understanding the local dynamics that oppress women, but it should be more of a question of how far we will be willing to go and how much resources we will be able to invest either through our own interventions or in support of existing local initiatives. So to go back to the point we were making before, there's already a lot of valuable work that can be done by supporting the work of local organizations that already understand the context and that already work on those very same issues.
Thank you, Diana. And I just want to be precise, it's not me saying we don't have time in humanitarian crisis, right? I am always with you. And I think I heard this sentence many, many times. So I do agree with all of you about that. And then I just want to ask a very general and I think a fundamental question when we talk about SRH, women empowerment, gender equality, because all of you said somehow that those are the main problems and barriers to implement a real MISP and SRH comprehensive care in emergencies, which is, I believe that when we talk about SRH, GBV, abortion, we touch the inner part of the culture of the people, their beliefs, their values. For example, when we want to prevent sexual violence, we disregard actually the extent to which sexism and misogyny and patriarchy in general shape inequality by defining and upholding restrictive gender norms and perpetuating such violence. I mean, sexual violence everywhere in the world, and then we know that the fundamental underlying causes are not epidemics or earthquakes, right? But they are also especially patriarchy and gender norms, which are there since the beginning of the world, probably. So my question would be for you, of course, we don't have time in emergency to tackle these fundamental issues. We don't have time to talk about gender inequalities, gender norms, blah, 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 right? We are here to save lives, so let's go ahead with that. Maybe do you think that prior to a crisis, a clarification of values regarding sexual and reproductive health, and specifically some taboo topics such as abortion, for example, within our humanitarian own organizations could be done? And then if yes, do you think that an analysis, so an assessment about how our own organizational systems perpetuate restrictive gender norms, because we must say we are not the best people in the world to not reproduce patriarchy and then gender inequality norms, right? I think we are all a female panel here, but I guess that we all know that no humanitarian organizations, it's perfect, right? We are still a long way to go, which is a good news, I think, but then still let's work on that. So my question is, do you think we should work in our own organization system to tackle this patriarchal norms and values that still exist within our own organizations? And do you think would be beneficial for the work outside during the crisis, or I'm just thinking about blah 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 useless things? So please help me find a solution. Yes, please, Amina, go ahead.
Yeah, thank you, Federica. I just wanted to say a few words before answering your question, and this is related to both the last question and even this question, really. So I think for me, and this is my personal view, I think feminist approaches or feminist initiatives should actually be referred to as humanist approaches. And why do I say that? Because feminism goes beyond sex, goes beyond gender or women's issues, as many believe, because of the way we call it. So if we consider really feminist approaches as humanist approaches, then all programs, all policies, all organization systems need to be infused with, these ideals. For instance, we know, and it's really basic, because if we know during emergency situations or crises, women and young people, or young girls especially, are the most affected when it comes to gender-based violence, then our solutions are just, evidence-based and targeted to the group of people that are mostly affected. So I think for me, it's really kind of humanist. And in terms of making sure that during emergencies, we are ready for action, we need to prepare well. We need to ensure that girls, women, everyone is actually empowered. They can be able to have agency to choose what they want for themselves. And then we also need to consistently focus on men and boys, if I may say, because they are mostly, unfortunately, the perpetrators. So they need to take part in solutions in addressing the root causes of gender imbalance. And then obviously, just one more point is also how do we infuse all this in pre-service training of health professionals at the various levels, because it will very much go a long way in sustaining MISP beyond the emergency situations that we're talking about. But then I come now to your question about organizations and how we can also, within our organizations, be sure that we also take the approaches to deliberately improve the system and the situations. So as at Pathfinder International, and it's very interesting because it is clear we are actually driven by the conviction that, all people, regardless of where they live, have the right to decide whether and when to have children, to exist free from fear and stigma, and to lead the lives they choose. So as a global health organization, we have what we call locally led, community-driven programs. We support women to make their own reproductive health decisions. And this includes comprehensive SRHR, and in many countries that especially the laws are, not as restrictive as others, This includes comprehensive abortion care. So for me, I think our experiences in countries like Nigeria with restrictive abortion laws is that we need to, and in all the countries, is that we need to ensure that there's values clarification, because these values and power dynamics often are often repressive of women and girls. I believe that everyone really involved in policy making or implementation or decision making, and not only for health, really, I think for all the social determinants of health, which includes all other sectors, housing, many education, all the sectors that are interlinked with the health sector, have to have their values clarified to help them recognize how their actions or really inactions affect others that may or may not share the same values or beliefs with them. And it could also impact the whole of community. So I'm very glad that, our organization Pathfinder, and many of the organizations that are on this table, we really take a deep focus into our values, and they're clearly reflected in our work. We review our policies regularly. We ensure that, the core values that we have of respect, courage, collaboration, integrity, innovation are really consistent across all the programs and countries that we support. No matter who you are in the organization, we have to uphold these values, especially as a leader. For us, leaders at the country level, at the global level, we are held really accountable by these values, and especially to recognize the differences that we all have. So in my view, I think this kind of organizational capacity for values clarification should also be infused in local organizations that are even closer to the people and most often are the first line of services or provision of care, even in emergencies. So this is just what I have to add. Thank you.
Thank you, Amina. Thank you very much. And thank you for making it clear. We're not talking about only MISP, we are talking about health. So we are talking about patients, any kind of patients coming for any kind of service. So this feminist approach, as you call it, and for me, you are totally right. It's a humanist approach. We're talking about human being, right? So it could be applied to any kind of person, regardless her gender or sex, or and regardless which service this person is asking for, right? So absolutely, I totally agree with you. But then I will leave the floor to Rania. I see she wants to contribute. So please go ahead.
Yes, it's very interesting. Like that. Like having a question like abortion and the value clarification for the communities is very important. But as Amina was saying, it's about preparedness and how to speak about these issues with the community prior to that. But also one of the things that we need to identify that there is a very big range on the platform of abortion in a humanitarian setting. Like harm reduction is also abortion service, because if we cannot go for the full-fledged, giving the opportunity to the parent or to the woman to decide if she wants an abortion or not, let's train our staff members to understand what's harm reduction and to save women's lives, not to punish her because of applying the punishment that she's coming from. Like she has done a sin and she's committing a crime in some context. So in that regard, WHO and IPPF have developed a theory of change for abortion, which is applied also to the humanitarian setting, and we are using the harm reduction model in almost all of our programs, and it's one of our new strategical notions to support with harm reduction models for abortion and self-care. In self-care is also another aspect, for abortion, which is what should be the end of the intervention from the medical professionals until it goes to the grassroots, and what is the meaning of having self-care. Self-care is not only me taking care of myself, it can be also my family. Another element into that, and also trying to navigate and dig more into those critical issues in the humanitarian response, is LGBTQI people living with disabilities, people living with chronic diseases, most vulnerable, diverse groups who are not recognized in the development setting in those countries. On those disaster settings, it's very important that when we are speaking about tackling those cultural norms, tackling the response, trying to optimize the response, that we consider all of those elements in the response, with strengthening our understanding of this diversities, their own needs, and how we can respond to it, and try to advocate for that in any context. I think this is all. Thank you.
Thank you, Rana. Thank you very much. I think you said it perfectly, right? And then I'm glad you are sharing with us a tool, because we are talking about things, and we want to have examples, we want to have tools, we want to have lesson learned from you. And a theory of change about abortion developed by IPPF and WHO is something we strongly need in our field, I think, because we need to change the minds of people inside our organizations, first of all, before going there and saying and preaching, yeah, you should be open on abortion. But then if we are not open inside our own organizations, how can we be responsible for our actions, for our words, right? If there is no examples of actions from our side. And then maybe Diana, do you want to add something? Yes, please, go ahead.
Yes, I would like to ask a question to Rania, if I may, and then also respond to your question.
Absolutely.
So thank you. My question to Rania is if you could share what you mean by harm reduction in relation to safe abortion care. Yeah, I don't know if you want to answer, and then I will add my contribution.
Yeah.
If that's easier. Yeah.
It's a tool that it's a tool that we are using at IPPF. I'm very happy to share, because recently, because it have been developed in our central office, I translated it, and we will be very happy to host a webinar for IPPF. I can share with you by the last week of October about it, but also we have it also translated into Arabic. So it's a production of long work with all of the MAs. So in that theory of change for abortion, you can see you can see how we can work with it, like a grassroots organization. What are the minimum that we can do if you don't have medical providers? And then the harm reduction model, which is applied in some of our settings where abortion is not visible. So it is educative to the providers of services and how to reduce the harm for the survivors, for the clients. We used to say clients in abortion setting.
Thank you. I think in innovation in terms of safe abortion care it's an area where there are huge gaps. So I'm very happy to hear about that. With regards to your question, Federica, I think we have a responsibility as organizations that provide sexual and reproductive health care in humanitarian settings to conduct analysis of gender dynamics and power imbalances between men and women inside our own organizations, so amongst our own teams, to understand how these play out in the way we deliver services or not, in the way responsibilities are distributed across our teams, male or female, to see how they play out in the way they speak to patients. And if I may, I would encourage organizations specifically to create spaces for discussion and analysis around two main issues. So the first is norms about women's control over their own sexuality and reproduction, and the other would be stereotypes about motherhood. So with regards to the first point, I think that many members of our own health teams are not always ready or willing to challenge certain norms and beliefs about women's control over their own sexuality when they are perceived as a threat to tradition. And very often I have seen how this immediately leads to fears about losing community acceptance, or perhaps even access to certain populations. So I think that these fears are very valid and should be recognized, but this shouldn't eliminate the importance of checking in with our own staff, how ready they are in fact to address issues related to sexuality openly and comprehensively. And specifically because I think this has a huge impact on access to sexual and reproductive health for adolescents. And for example, are our teams ready to talk about not only safe, but also pleasurable sexual experiences? If this is an approach that perhaps resonates more with those age groups, I mean, have we checked if this way would resonate more with those groups? I mean, there's excellent guidance on adolescent sexual health from the Interagency Working Group on Reproductive Health in Crisis, which clearly lays out that adolescents face very specific barriers to services like contraception because of provider bias and limitations to having age-appropriate and scientifically accurate information. So from a feminist perspective, I would say that at the root of this is in fact more than a fear to lose acceptance, is a lack of willingness to address issues related to sexuality openly. And you know, certain norms that we're not ready to challenge when they are a threat to the dominant patriarchal order. So then, and I would also say that working in places like Yemen, myself, I would argue that discussing these aspects is 100% possible in any context, including those that are very conservative and religious, in as long as appropriate spaces for discussion are created where people feel comfortable and safe to express their views. So I think sometimes we have to get creative to achieve this and explore possibilities with our own teams, but not shy away from the task with the excuse that it's too sensitive. You know, communities have a right to safe spaces to access information and to scientifically accurate information. And so the second aspect that I suggest organizations to discuss internally is the weight of stereotypes around motherhood and the extent to which these stereotypes lead to our projects being focused on heterosexual persons and on women of reproductive age. So I think that at the root of these stereotypes are patriarchal structures that assume that all women want to be mothers and that all mothers find joy and purpose in motherhood. So while this may very well be true for many women, the problem here is the generalization. And my point here is that it's important to assess the extent to which these stereotypes contribute to the resistance among our own health staff to provide essential services like safe abortion care, or or that influence the extent to which our services are directed at heterosexual women or only to women of reproductive age. So yeah, I think it's really important to create spaces to explore these perceptions within our own teams, to analyze the extent to which the patriarchal family structure is perceived among our teams, because otherwise we may not be realizing how much they contribute to judgmental care and how much they may be reinforcing restrictions on women's ability to decide for themselves about how to live their sexuality, about birth, or about pregnancy. Thanks.
Thank you, Diana. I see all the other colleagues waving, so I think we are getting there where we want to go, right? The problem is patriarchy, of course. We all know it. Let's say it loud. But not only, I think, you know, as you said, I think also, and then probably doctors out there will kill me, the Western construction of medicine also, it's made to say, we know what's best for you, and then you don't have to ask you, a normal woman in between your 30-something age, you want children, you want it this way. And then of course we leave out some specific minorities, for example, LGBTQ IA plus minority, we leave it out because it's not in the norm, right? It's not in the norm of medicine, on how we construct also our bodies and how we reflect about that. So I think it's a huge number of layers, right? It's a multi-layer problem, right? But then we're running out of time and we have few interesting questions. So if you don't mind, I will ask you a last question and you have like few minutes, few seconds to answer, which is, in a dream world, what activities or objectives you'd like to see in a new version of the MISP? Is there something you would like to add or to eliminate or to get more funds on? And do you think it's not funded enough? I don't know if it's clear. I can see you were brainstorming in your own mind. Rania, want you say something?
Yeah, like being a trainer for MISP for the last 10 years in all of the versions. I think that there is more trainings that we should do on the, in advocacy for MISP. And I'm saying that because it would be surprising to say that even in the Arab world, which is an area of protracted crisis, and which is like the crisis here have existed for longer than any other regions, and the focus of the globe was there. Speaking about Palestine for the last 30 years, speaking about Yemen for the last 8 years, speaking about Syria for 10 years, still there is no buy-in for MISP interventions. It's very weak when it comes. Unless it's coming from inside of the health cluster, nobody identified as a standalone because it's a protracted crisis, it's a too long one. So what I want to see, it's more advocacy tools and advocacy training for those donor communities. And also guidance, in the other hand, on how to work with grassroots organizations. So just to have it in the middle, because I think until now, and during all of this, development from MISP 1 to 2 to 3 until we, until the revision that we in between our hands now, there is no tool which is telling you directly, this is how you work with women grassroots into how to speak about sexual reproductive health in crisis situation. Although there have been a lot of preparedness activities which have done this with grassroots organizations. So can we collect all of this and work on it and make it as a tool that we can use? This is my 2 points. Thank you.
Very, very fair. Very, very good. Please, Amina or...
Yeah, yeah. Thank you, Federica. And I think Rania has mentioned it quite well. But just to add, that for me, I think there should be maybe an objective or a cross-cutting element around gender, because, it seems as if many of us, there's a huge gap or difference in what people really envisage or think about what gender really is. So maybe just a bit of gender training activities or, elements, so that at least it is clear what really, we're doing and we're trying to implement in a gender equality world. And the second is also the values clarification arm that we talked about. Is it possible for us to also have it very clearly stated in the MISP tool, and also the elements of even the values clarification, such that we know it's a uniform kind of values clarification methodology, and it helps to really, help clarify and understand what the issues are in each of the communities, and to be more specific in terms of what really we need to do to address whatever comes out of the values clarification. So I think this is important. But then also just one last thing that I said earlier, how do we ensure that MISP is also very much integrated into pre-service education of our healthcare providers at the various levels of care, especially community-based providers, because it's not accepted or it's not used. Maybe working with the pre-service institutions would also be a very important, advocacy tool, would be an important strategy to improve the utilization of the MISP tool. Thank you.
Maybe in 1 minute, I will try. Mina, I really echo Amina's point on making sure that it's disseminated among healthcare providers. So I think that perhaps rather than adding new elements to the MISP, it's something that needs to be better understood and shared among the sector, yeah, it's something that we should all be advocating for and disseminating more broadly. Thanks.
Thank you very much. I think the wish list is done. Everybody took notes, and then in the next revision of the MISP, probably also chaired by Rania, which is always there in the revision of the MISP, we will add trainings and clarification of values, and then preparedness, which is, I think, something we are seeing since a long time now. We are no more in a world with new crises coming up. We are seeing the same crisis going on and on and on. So maybe we can still take some time and then step back and then implement something more, how can I say, durable and then realistic, and then also more comprehensive, right? That's what we were saying. I think we are running out of time, and then I think we cannot steal more time to our colleagues, right? Can we? If there is no news, good news, so I think we can go ahead for 5 minutes. I decide very undemocratically that I will take 5 more minutes, and then I will take one of the questions, which is, I mean, I saw 2 questions in the chat, which are very similar, the one to each other, so I'll try to resume. So the question was, local organizations, how can we work with them, knowing that sometimes they are fighting with their own government. So, and then also objectives of us as humanitarian people can maybe completely be different, in a completely different way from local grassroots organizations, which are more, let's say, development organizations. So how, if we can maybe, and maybe you have ideas and solutions how we can match our objectives and targets to make it work and make it, with an impact as in local organizations. Yes, Diana?
Yes, I saw this question. I think it's an excellent observation, and it's not easy. And I won't give an answer pretending that it's a straightforward process. But I think it's important to identify actors that share our same objectives and our same values, and then decide, how do we use the power that international organizations do have to support and echo those same objectives. So, for example, how can we learn from the work that they do to try and use the relationships that we probably have with authorities to advance their goals, which in the end are the same as ours. So it's for sure not a straightforward process, but I think this is an example of how we should reflect upon the power that international organizations have and see how we can support those local initiatives that in the end are trying to achieve the same goals as we do.
Completely. I don't know if Rania or Amina want to add something on top of that.
Yeah, I like the start point that Diana was tackling, is just to verify that their alignment with our values before we go in and we dive in. And I'm someone who don't believe personally on conflicts when we are doing good things. So if it's good and the willing is good and the aim is good, everything should be aligned in one setting. And I cannot, I cannot recall there is there is a conflict and there is people who are conflicting what's the meaning of good. It is always aligned, but the problem is how we are articulating what we are doing in the way that the others can understand. So that needs some conflict resolution, techniques. But I don't believe that for a sexuality agenda on SRHR, there is an opposition. People are just not understanding each other.
I think quickly, Federica, just to add here that I think for me, that's why values clarification is still very important, because by the time we all interact both with with the international humanitarian organizations, with the local organizations, when there's a very clear values clarification exercise, or we address all these, who realize that yes, we're all in this together, even though different organizations have different approaches. But secondly, also in my view, and with the experience that Pathfinder has in working with countries like Nigeria, really there's a lot that needs to be done with advocacy, because if you're working with advocates, you know how to really package your information, package your strategic approach, and even the governments would really find it difficult to challenge all these. So working with local media, working with young people that have the voice, that are very active in social media, what we did in Nigeria, especially with our advocacy project, is recognizing that strength, because sometimes you don't even know what is out there, the strength of the media, the strength of those young people that are out there doing a lot of work, but just bringing us together, having that coalition is what really both the international organizations and the local partners need to do, so that we can have a stronger voice and we can be able to, walk the path and, approach SRHR and all the humanitarian issues, with the same strong voice. Yeah.
Thank you all very much. I think we will close it down. Just simply, if I can resume quickly, I think we all agreed on the fact that the big problem, underlying problem, is patriarchy, but also that we need more trainings, and we need to see the problem and talk about this problem, because it's not a taboo. We need to, address it. We need trainings, we need advocacy tool. We need to work with feminist organizations, knowing that less than 0.6% of the global official development assistance goes to women's rights, local women's rights organizations, and it's a shame, I think, to be honest. And then I just want to remind to all of us that the MISP is actually a health system intervention, so we are not talking about magic, we are talking about doing something practically. And then to be efficient, as you said, and I agree, the MISP has to be holistic, completely implemented in all the parts, and maybe adding more parts, as you say, in order to prevent SRH-related morbidity and mortality. So just to close down, thank you very much all. Let's talk about taboo, let's talk about abortion, let's talk about access to SRH. And then thank you very much. I leave the floor to our colleagues in the next very, very interesting panel about Afghanistan and SRH in Afghanistan. So stay tuned. I think it's going to be a very interesting panel as well. Again, don't hesitate to tweet about the Berlin Congress with the hashtag HCBerlin. Thank you to my brilliant colleagues. Thank you very much. I'll see you on the ground in the field to implement a MISP. And then thank you very much. See you soon and have a nice day.